Arthur Robin Williams is an associate professor of clinical psychiatry at Columbia University's Division on Substance Use Disorders and a research scientist at the New York State Psychiatric Institute. He attended Princeton University's Woodrow Wilson School of Public Health and International Affairs for his undergraduate degree in domestic health policy, and he completed his medical degree at the University of Pennsylvania, where he also earned a master's in bioethics. Dr. Williams is also the chief medical officer and a co-designer for Ophelia Health, telehealth provider for people with substance use disorder. Welcome, Robin.
Thank you for having me.
Right off the top, I should say, lest there be any confusion, though we share the same last name, Robin and I are not related.
That's a good point. Yes.
I have a quote here. Yeah, I think it's taken from an article that might have been in the New York Times. I'm not sure. But it says, Dr. Williams, the medical director, said, when I first heard about Ophelia, I was terrified. I thought the idea was ludicrous. He worried about doing proper clinical management over video. Could you tell us a little bit about Ophelia, what it is? And then also, I'm curious, you were terrified, but yet you're a co-designer of Ophelia. So I'd like to get the timeline squared away, in my mind at least.
Yeah, happy to. So some context here is that if you think back, it can be a little bit hard to think back pre-COVID in terms of how everything operated now that it's been 5 years. But in the teens, I guess you could say, 2015, 17, 19, before COVID, there were some companies that were being formed that were providing often cash pay services, subscription services for various pharmaceuticals. And it raised concern among the psychiatric community that basically you had an algorithm that was overseeing, so to speak, clinical management, where people would fill out forms online and then they'd get mailed all sorts of medications, some of which really do have side effects, even if it's for a small percentage of the population. It can cause significant harm. And yet there is no real oversight. So in 2019, when our founding CEO at Ophelia, Zach Gray, reached out to me and my counterpart, Adam Basaga, who's a clinical trialist, also full-time at Columbia with me, Zach reached out to us because he had a girlfriend who died, who was found dead at work from an overdose. And he was finishing his business school program at Wharton. He's from New York City, went to Columbia for undergraduate, and was at Penn for Wharton, and just couldn't believe how difficult it was to try to find help for her. They had gone to 3 different doctors. 2 of them claimed that they couldn't prescribe buprenorphine. The third one, she didn't feel comfortable disclosing that she'd become addicted to opioids. And so she was buying Suboxone from her dealer because it was easier than getting it from a doctor. It's unbelievable, right? And yet this is something that is commonplace throughout the country. Zach was very motivated to think about how do you create a low threshold treatment program to make treatment convenient and private and discreet, and to really get it to so many people who need it. It's probably 80% or so of people, 7 million people with opioid addiction who don't have treatment in a given year. So there's this huge unmet need in the country. And that's why we started Ophelia. And as I started thinking about it, buprenorphine, which is an FDA-approved medication to treat opioid addiction, it's risk protective. You think about other controlled substances, stimulants like Adderall or Ritalin, benzodiazepines like Xanax, they're risk conferring. But buprenorphine saves lives. Every day someone's on buprenorphine, their risk of overdose or death drops by 68%. So it's really a question of how do we get this out into the community, to the people who need it. And telehealth is actually a great platform for doing that, especially for patients who have children, who have jobs, who can't miss work shifts, who don't want to or can't pay gas money to drive across the county, every week or even every day to go to a clinic and sit in a waiting room for 40 minutes and then be seen for 5 minutes and then drive back on the other half of the tank of gas. Telehealth brings the treatment directly to the patient. So the more that we talked through this and what this could look like, and then COVID, sort of blew up all of the regulatory constraints in terms of in-person requirements. And we were able to start 5 years ago treating patients in New York and Pennsylvania. Those were our first 2 states. without requiring any in-person services. And that's still true to this day. And we've seen over 20,000 patients. It's been very successful.
Um, how did Zach know to reach out to you, other than obviously the fact that you're a psychiatrist?
So Zach found Adam Basaga. He had just published a book, Overcoming Opioid Addiction. And that was on Zach's radar. And he reached out to Adam. Adam looped me in, and we started talking about what the barriers were. Why is it that only 20% of people who need treatment are able to get it in a given year in the United States? And it's not just one or two things. It's really a laundry list of barriers that get in the way.
I'm all too well familiar with those barriers.
Yeah.
Most everybody that listens to the show knows we lost my son in 2012 to a heroin overdose. So, um, and we spent probably the prior 2 years trying to jump through all the hurdles that are out there.
Yeah. It's just a tragic story. And I'm sure you're very familiar with this. The study that showed it was something like 40% of people in the country have a family member or a close friend who've dealt with this or died from opioid addictions. It's very widespread. And I think we've had a bit of an uncoordinated response. If you think about the drug market right now, the biggest drug dealer in the United States is social media. So it's Instagram and TikTok and Facebook, and that's where people get drugs. And so I think if you want to fix this problem, if you want to address the drug death crisis, you really have to make treatment more accessible than downloading TikTok as an app. You have to get it into people's hands onto their mobile. So our whole treatment platform is very mobile friendly. And that way people are in distress 7 days a week at any point. We don't have to turn the lights on in a brick and mortar setting to be able to help them. We're available not 24/7, but 7 days a week. Very accessible.
Um, Simple question, but I've been curious since I first found out about it. It's named Ophelia. Was Zach's girlfriend's name Ophelia, or was it chosen because the meaning of the word?
The meaning of the word, his girlfriend, her name did start with an O, but the root, the meaning of the word in terms of helping people in need, that was the real motivation for it.
Got it. Believe it, believe it or not, I took Greek when I was in high school,
Uh-huh.
and so I went. I said, "Let me check this out." There, there it was. Um, so once you were found, what went into what did you have to do to what was your role in particular?
So we have, this is where it all seems simple on the front end, and then you start doing it. There's thousands of layers. We have almost 200 people in the company at this point, about half clinicians, and then half are a whole mix of administrative personnel, engineers, tech resources. We built the whole EHR from the ground up to both satisfy clinicians and also to optimize patient outcomes and give us the ability to monitor outcomes. So in terms of my role, I've had 10 years or so of NIH funded studies looking at large health systems data, EHR records, Medicaid, insurance claims, and looking at care episodes in these large data sets and how people enter care, how long they're in care, how they respond to treatment, and how that's related to acute service utilization. So you think about emergency department visits, inpatient hospitalizations, the things that are really costly, but also reflect danger or harm, where people are at risk of injury or death, and having that work in mind in terms of designing our EHR, we really wanted to have structured, what you might call structured data or structured variables that we could analyze to better understand who is entering care with us and which patients do well and which patients need additional kinds of support. So it was a very purposeful design, not just in terms of our clinical protocols, but also the EHR, so that we'd be able to understand who is entering care with us and how to have different care pathways for those patients. I've published a few studies of large samples of buprenorphine patients over the last 10 years. And what has become apparent is that there are some patients, when they enter care, they're already taking buprenorphine. And clearly some of those are care transfers. So they're moving, or they have changed in insurance, or for whatever reason, they want a different prescriber and they come to us. But most of those patients are actually getting buprenorphine from the street. They call it street Suboxone and street bupe, or they're getting it sort of unofficially through someone else who has a prescription, and they're seeking relief from addiction. They're trying to treat withdrawal. They're trying to get into a formal treatment program and struggling. Wait lists, all of these things. The patients who come into care who are already taking buprenorphine, it's not a surprise, but they retain and care about twice as long as the patients who come in not on buprenorphine. And they have about half the rate of opioid use while they're in care. So they do better. The flip side of that is that we can identify the patients entering care who are more likely to struggle. And we determined that about 20-25% of the patients who enter care with us, and these are disproportionately younger men, actually, so 20s, early 30s, and males, who are actively using street drugs, which these days, as you said, that basically means fentanyl. Whether they know that or not, about 80% of our patients test positive for fentanyl, even if they think they're using opioids or benzos or whatnot. And these patients who come in using street drugs who are not on buprenorphine and need an induction to get onto buprenorphine, those are the patients that we're more likely to lose in the first few months of care. And those are the patients we worry the most about. So we created a whole treatment pathway for those patients with a more rigorous combination of medication and counseling to try to treat withdrawal symptoms, to try to help with co-occurring psychiatric conditions that may destabilize their early treatment response, to really do everything we can for this sort of higher risk segment of people coming in. But the reason we were able to identify these patients is because within the EHR system, we had it set up in a way where we could characterize the people entering care and figure out who is struggling with early engagement and longer term retention.
I think you're being modest. You said you've done a few investigations based on what I've been able to look at, discover on the internet and stuff. You've done more than a few.
Oh, thanks. Yeah, it's this is actually a new era because now Medicaid, of course, is very much in the news right now with the whole debate around the budget bill. Medicaid has grown a ton, and it's not just that more people are enrolled in Medicaid since 2010 under the Affordable Care Act, but there was a change that most of the public probably wouldn't be aware of. There was a change in basically the anonymity of Medicaid claims in terms of patients receiving addiction treatment services. And it was fortuitous that when I started my research career after my residency and fellowship and my postdoctoral fellowship that was funded by the NIH at Columbia in 2014, that was around the time that Medicaid was no longer redacting insurance claims information about addiction treatment services. So that early on there had been this a well-intentioned protective impulse to strip out addiction treatment services because the concern was that this would be stigmatizing or could be used against patients. Of course, any research it's more or less they take out the protected health information for the analyses. But the point was that about 10 years ago, not only were more people enrolled in Medicaid, but we were actually able to study addiction treatment care episodes within the data. And this really wasn't possible until about 10 years ago. And so that opened I don't know about floodgates, but it created the possibility to understand what was happening for millions of people. When you think about fentanyl addiction, heroin addiction, it's about 4 times more prevalent in the Medicaid population than the general population. And some of your audience may be aware that for people under 65, so non-seniors, if they have a disability, they can qualify for Medicare. And so we think about this population as the dually eligible population of people who can have both Medicaid and Medicare due to disability. And the prevalence of opioid addiction for these dually eligible patients is about 12 times the general population. So we did not set out at Ophelia to be what we've become is really a Medicaid health home in a lot of ways for patients with an opioid addiction. But when patients started coming to us, and this was through online ad, people were on Google, Facebook, whatever, they're Reddit, they're looking for information about getting treatment or how to deal with heroin withdrawal or how to fix their problems with fentanyl, and they get a pop-up ad for Ophelia. They just go to ophelia.com. They can come to us, and it became very quickly apparent that about 80% of our patients had Medicaid. And if you look at who in the country is addicted to opioids, it's also about 80% of them are Medicaid beneficiaries. So we've become very familiar with Medicaid. In the state of New York, we have almost 20 Medicaid managed care organizations. It's just a ton. You look at other states, Connecticut has one, it's a smaller state, but they have one Medicaid program. So we've had to negotiate and meet with these 20 more or so Medicaid MCOs in New York. It's taken 5 years, but we're now more or less in network with all major insurers in the state. So we do have patients who pay cash, but the great majority of our patients are able to use their insurance benefits, and we have a very good relationship with the state agencies, the New York State Medicaid office, and we're actually partnering with them to try to study how our patient results compare to the results for legacy brick and mortar providers. And as far as we're aware, and based on, we've published now 6 or 7 peer-reviewed studies, our retention is much higher. And I think it speaks to the convenience and the privacy of the platform. We have way more patients making it to this, what you might think of as a critical milestone of 6 months continuous retention. And that's 60, 70% for us. Whereas if you look nationally, it's more about 28, 30%. So we have about double the retention than you see in traditional care settings.
What are the obstacles? I don't want to say competitors, but who gets in the way? Who are the naysayers? That's what I'm really asking in terms of telehealth and what you're doing. I mean, what you've described, there's so many positive results, and yet
Yeah.
there are naysayers.
So a key part of this whole story is the Ryan Haight Act, which Congress passed in 2008. And Ryan Haight was a young man who died from an opioid overdose, and he'd been buying opioids, pills, online. It was basically an online pill mill. And there was a physician who'd signed off on this prescription, but it wasn't genuine medical care. And that caused a bit of a firestorm. So, this was 20 years ago when he died. Well, you think about Congress, 20 years ago, probably none of them even had an Amazon Prime account at the time, right? So this idea of sort of getting a controlled substance online seemed very taboo or problematic. And so they passed this law called the Ryan Haight Act in 2008, which required in-person visits in order to prescribe controlled substances. So people really looked askance at the, so to speak, online provision of medical care, especially if it involved controlled substances. This all got upended with COVID, and I think there's still an impression that telehealth is a beta version of in-person care, because the assumption is that in-person care is superior, and because of COVID, we all scrambled and had to create workarounds to try to help people without exposing them potentially physically to viral risk. And I think what we've shown very convincingly is that telehealth for some conditions is not attempting to replicate in-person care. It can actually be very much superior to in-person care. And I think that's especially true for behavioral health conditions. Clearly, there are all sorts of things that are impossible to treat on a telehealth platform, but there are some things where it's a very good fit. So who are the naysayers? Well, you have legacy brick and mortar programs. They're worried about competition in terms of patient volume. Law enforcement in general, historically, and this isn't just in recent years, this has been for over 100 years, law enforcement has been very, and I'm speaking very broadly here because we have a lot of allies and champions in law enforcement, but overall, our country has had tension between law enforcement and public health or medical providers around opioid addiction. And there's concerns about what they call diversion, which would be someone who's getting a legitimate prescription, but then selling or trading some of that or all of that prescription. And the concern is that this is nefarious black market activity. In reality, and there are many, many studies on this, when there is, quote, diverted buprenorphine, the great majority of the time, meaning literally like 95, 96% of the time, it's being given to someone in need. Someone is using it in order to treat withdrawal, especially if they're struggling to get into a program. So it's very different than you think about these other controlled substances I mentioned a moment ago that are really risk conferring, like stimulants and benzodiazepines that can be misused and cause all sorts of chaos. It's very rare that you would see a pocket of buprenorphine, like a buprenorphine epidemic in North America. It's happened, but in general, people use it to treat themselves or to try to better manage their heroin or fentanyl use. So in some ways, it's sort of this act of desperation. But law enforcement's very concerned about diversion. We have a drug testing protocol that we actually published in JAMA Health Forum 2 years ago, because the number one question we got was, well, how do you do drug testing? How do you monitor for diversion? And there's a
Yes,
misconception
and
that you're
I confess to having. Sorry to interrupt. I confess to having that as I began to read. Every time I read something or I had a question, then I would. It's almost like then the next thing I would read would be one of your studies, and it would answer my question. So please go ahead, because that was exactly the one of the things that popped into my head early on.
the first question we get is, how do you monitor for diversion? And we got so used to that after a few years. I thought, you know what, we should publish a study, and we were thrilled that it got into a really high impact journal. What we showed was that it's very feasible, very acceptable to have a drug testing protocol exclusively in remote care settings. I have a private practice in New York City at Columbus Circle, and I see patients in my office and have dip cups, and they can put a specimen in the cup, and then we open, you peel off the label in the session. It's a 14 panel cup. And we basically replicated that for our treatment platform. So when people come to Ophelia for care, we ship out 2 drug testing cups to their residents. And after their first visit, if they're deemed eligible and appropriate for care with us, we'll prescribe buprenorphine. They start buprenorphine, and then within a week, they have a follow-up visit. And that's where we want to have a drug test to show that they are taking buprenorphine. There's a misconception that drug testing is required. There's actually no requirement for drug testing for treating patients with buprenorphine, but there is a requirement for a diversion management program. So you have to have some sort of protocol in place. Part of the confusion here is that patients with opioid addiction treated in methadone clinics, which are technically called opioid treatment programs or OTTs, those patients they have to be tested. I think it's 8 times a year or something like that. And drug testing is rife throughout the addiction treatment space. Well, I'm sure you're very familiar with this. And part of it is because the costs of having a brick and mortar setting often necessitate, especially for providers that have a lot of Medicaid patients where there's low reimbursement, they use drug testing as a way to drive revenue. And so there's this over testing or overuse of testing that I think can become really problematic for patients. It's not patient centered necessarily, it's a way to get revenue. So we've been very adamant that we're never going to bill for drug testing. And we never have. We've never required groups, which is another way that brick and mortar providers have needed to generate revenue to cover their costs. And so this gets to not just the effectiveness of telehealth, but also the cost savings of telehealth. And it's really a way to scale low threshold access to treatment to a lot of people who otherwise wouldn't be able to access it. So what we showed in the JAMA Health Forum study was that we had almost 100% completion among the patients who started buprenorphine, and being able to have a specimen presented in the session following their induction, recorded in the EHR. And then we looked at the patients who stayed in care for at least 6 months. And what we found was that on average, they had about 3.5 drug test results recorded in the first 6 months of care. And that's very much in step with our protocol, where patients come in, we usually see them weekly. As they stabilize over time, their visits are stepped out to every other week, eventually for some patients monthly visits. And at each of those junctures, we like to have a drug test recorded. But the use of it is really patient-centered. All of our patients have opioid addiction, but depending on what we're talking about, you think about stimulants like methamphetamine or cocaine, alcohol, cannabis, there may be other things that patients are trying to work on, and that's where the drug testing can be helpful. It's not just necessarily about opioids.
So when you say 14 panel, actually you're talking about 14 different substances that can be detected?
Yeah, that's exactly right.
Okay. Um, wow. Well, that was certainly one of my questions. And so you have a high compliance with the urine testing,
We
correct?
do. Yes.
Um,
There have been concerns about manipulation of the results in a telehealth setting. And we looked around, and in the literature, it can be as high as 10-20% of uh, specimens in person care settings that are adulterated. So it's not only a concern in a telehealth setting. There's always that possibility, unless you, and this is rarely warranted, but unless you're in a professional lab with a forensic level uh, of chain of custody in terms of the specimen, that there's always that possibility. This gets to the patient provider relationship, and our patients are extremely satisfied, our clinicians are extremely satisfied, and we have really strong therapeutic alliances between the providers and the patients. So that's where we really think about drug testing as a tool or a mechanism to support treatment goals for the patient, and we can individualize that for a given patient. And there are some patients where drug testing can be very frequent, and then others where it's clearly not necessary at all, especially if the patient doesn't want it.
and the patients have some more than little control over that.
They have a lot of say in it. There's some provider variability. We have some providers who are among our clinicians who are a bit more conservative, and then others where there's a mix. And I think it's healthy to have that heterogeneity across the clinicians, different perspectives.
When you say clinicians, we're not talking just MDs now, are we?
So that's a great question. There is absolutely no evidence that the qualifications of the provider, of the prescriber, have an association with outcomes. And this is something we talk to plans about on a regular basis. The treatment outcomes are just as good, whether the prescriber is a physician or a nurse practitioner, a physician associate, whether they're a behavioral health specialist or a generalist. Opioid addiction is a behavioral health condition. It's in the DSM, the handbook more or less of psychiatric diagnoses. And yet, if you look at buprenorphine in the United States, 80% of it is prescribed in a general care setting. It's the same as SSRIs for depression or anxiety. 80% are prescribed in general care sessions, care settings by nurse practitioners or physicians or PAs. What that means is that we'll never have a sufficiently robust behavioral health workforce to treat everyone in need. And often these are conditions that can be treated in a primary care clinic or something like that. Our care workforce are largely advanced practitioner nurses. We do have some physicians and PAs with us, but it's mostly advanced practitioner providers, and the results are really strong for basically for nurses, for nurse-based care. We adapted. Some of your audience may be familiar with the Massachusetts nurse care manager model, and this came out of the aughts when buprenorphine was first FDA approved to treat opioid addiction, because there was awareness that with the OxyContin epidemic that there would be way more patients in need than psychiatrists would ever be able to reach. So you think back, buprenorphine was approved around 2003, and when it first came to market, 80% of it was prescribed by psychiatrists, probably mostly addiction psychiatrists. And that has now flipped, where, as I was saying, now the great majority of buprenorphine is not prescribed by psychiatrists or mental health specialists. It's prescribed by generalists. So our workforce are largely advanced practitioner providers, and that allows us to treat patients at a lower cost, which is really the only possible way to make the numbers work when you're dealing with Medicaid plans.
Addiction is a family disease, and I'm wondering, being able to use telehealth enables people to stay at home, and is that always a good thing?
So one of the concerns with telehealth is not being able to observe the patient, uh, in a clinical setting. And sometimes we have a large referral system, and we do have contracts with pro labs like LabCorp and Quest, and there are sometimes needs to have the person physically present. That being said, when you're in a clinical setting, it kind of flips everything, where you're in this sterile environment, and the patient is showing up, and you're seeing this version of the patient in the clinic. When you go into the person's home life, you can see and learn all sorts of things that would never be apparent when they come into the clinic. And so we routinely have patient visits where you have the kids running around, you have animals in the house, you can see the condition of the apartment or the home.
Right.
You can understand the person's life in all sorts of ways that just by them telling you about it, you may not appreciate some of these things. So there are all sorts of advantages here, again, where telehealth can actually be superior in a lot of ways to our traditional approach to care, which required people coming in person on a regular basis.
Yeah, I see that. To your point, I mean, as we talk, I'm paying attention to the lamp, the mirror, the stonework behind you. I don't know what the setting is, but it does give me information. Let's leave it at that.
Yeah, and especially if there are other people, right? And you see the interactions with the partner or the kids,
Yeah.
you can learn more about the patient.
Um, you have the number of people that pay rather than use Medicaid. Are they more likely to stick with it longer because they've got their own financial investment?
That's a great question. We actually published this study in Health Affairs Scholar a couple years ago. We have a whole mix. So you can think of it, this gets a little bit complicated, but three different categories. So you have people who have insurance and they're in network, so they're able to use it. But among the cash pay patients, it's actually a combination of people who have insurance, but they're out of network because the plan has refused to contract with us. It's really shocking, but we routinely are told by public and commercial plans that they have, quote, network adequacy. They say, oh, well, we have enough providers in network. We don't need to add another provider for opioid addiction. And it's just really hard to believe on the surface, given how many people struggle to find treatment. When you dig into the numbers, it's very clear that they're incorrect, and they don't have sufficient provider availability. And we know that in part because we have patients who do have insurance coverage, and yet they're choosing to pay cash to us. And I think that's a strong argument that they don't have the option of using their benefits, because if someone can get something for free or low cost, usually that's going to be what they do. We only charge $245 a month is the cash pay fee, which is below market, frankly. And yet patients still choose to pay cash if they can't use their benefits. Your question, though, about how people do and if they retain, what surprised us was that when we looked at the cash pay patients, the ones who had insurance, they were actually more likely to drop out a bit sooner than the people who were uninsured paying cash. And I think that does speak to, over time, people, especially as they stabilize with us and they're doing better, and they look around, they can find providers who are in network, but it can take some time to do that. So we think of ourselves early on, 5 years ago, we started as a standalone provider. But now we also function as a supplementary provider where we partner with all sorts of different treatment programs, carceral settings, jails, prisons, but treatment programs, IOPs, group-based programs that don't have a medication or a prescriber available. And then we also think of ourselves as a bit of a safety net And so we have a bridge clinic that we set up. We have patients who are sent to us. There are various scenarios where they may come to us, and we all know that this is for a few weeks or a month while they're moving or getting set up with a different kind of provider. But in the meantime, we're able as a safety net to continue their buprenorphine prescription until they settle into a long-term program. So there's just a lot of flexibility and adaptability to a telehealth-based program because we can operate statewide. We have much more expansive hours. We're not restricted, to 9 to 5 in-person hours. We have evening, weekend services available, and so that allows us to innovate and do all sorts of things that traditional programs would otherwise struggle with.
I should have asked this earlier on. What drew you to addiction psychiatry?
So I, in high school and college, had worked on various HIV prevention efforts, AIDS awareness campaigns in the U.S. and in developing countries. And I was, as you mentioned, I was in New Jersey at Princeton for college, and there was a governor race, and we started talking to the presumptive nominee who did wind up becoming governor, because in New Jersey there was the highest rate. So this was in the early aughts and the late 90s, the highest rate of mother to child transmission of HIV in the country. And you think about a northeastern state, somewhat progressive at the time, but kind of a purplish state might be how we would refer to it now, 20 years ago, and relatively high income, one of the wealthier states in the country. And it was perplexing. Why would you have this high rate of infant HIV transmission? And it really was because of drug policy. It was because the state disallowed needle exchange programs or syringe service programs, disallowed over-the-counter sales of paraphernalia without a prescription, and it criminalized possession of drug paraphernalia without a prescription. So if someone had needles or syringes, the presumption was that it was for drug use, and so it was criminal. And these were laws across the country that mostly in the coastal states, the Northeast, were passed because of the heroin epidemic in the 60s and 70s. Because of the HIV epidemic, most of those states over the 90s repealed those laws because they realized they were actually creating a lot of harm rather than being protective, which is not a surprise because in general, law enforcement-based approaches to addiction don't outcomes. They just send people away to carceral settings. So the long story short was that it was really through HIV prevention efforts that drug policy became a big part of what I was working on. And I knew I wanted to go to medical school. And through training, it became apparent that addiction psychiatry was really the home for me in terms of my interests and the kinds of patient populations I'd been advocating for and working with over the years.
You are certainly not the first physician or the first person advocate that I've talked to whose inspiration, for want of a better word, came out of the work that they were doing in HIV/AIDS prevention. Um,
There's a lot
and
of
certainly,
overlap. Yeah.
certainly, the Maya Sullivan's book on the history um, tells us a lot about that. I'm blanking on the title right now, but
Of her book or the
yes.
my Unbroken Brain was a
No,
big.
she wrote one that's the history of really the history of harm reduction.
Oh yes, yeah. We've had great partnerships with infectious disease clinics, HIV clinics that have, at least in the New York area, often had interest in terms of building out buprenorphine programs and actively, proactively treating substance use disorders and opioid addiction among their patients.
Uh, where do the have insurance companies learned? Are they beginning to learn, or do you still have to hit them over the head that it's cost effective? The telehealth, such as you're offering, is cost effective for them.
It's a struggle. Uh, it is cost effective, and yet it's highly cost effective, and yet the plans. What I've learned, the plans are not necessarily incentivized at all to pay for this. I think that the opportunity is actually really with the state. Yeah, the state of Pennsylvania is a great example. They created the Center of Excellence program, the COE program for buprenorphine providers, but for providers for opioid addiction. And the state actually pays a bundled rate every month for the patients in care through the Medicaid plans for these high performance providers. And we're actually the first and only telehealth provider that's gotten the COE designation in Pennsylvania. New York doesn't have a program like that. We're actually going to Albany on July 24th. They're having a summit on telehealth for the opioid crisis, and hopefully that will go well. The plans, are, it's not a surprise. It comes down to the dollars. And so they're thinking about what they're paying out. And they, part of what complicates this is that a lot of the costs are driven by acute service utilization. So the patient's winding up in the emergency room in the hospital. I had a patient years ago in my private practice who was trying to get on to extended release naltrexone, had Medicaid, and Medicaid would disallowed me from prescribing the extended release naltrexone because he had to be with a Medicaid accepting primary care doctor, and that person had to prescribe it. So this is ridiculous. We were in New York City. He went out to Long Island because that was the place where we found a provider. He gets out there, and the physician says, "Oh, well, I can treat you, but I cannot give you the extended release naltrexone. We have to order it. You'll have to come back in a few weeks." And in the meantime, the patient was still, injecting heroin. This was 15 years ago, and got a horrible heart infection that required he had sepsis, not just IV antibiotics for weeks in the hospital, but part of a replacement of his heart tissue. So this was a multi-million-dollar hospitalization. That would pay for buprenorphine or for evidence-based FDA-approved medication treatment for many, many patients. So some of these costs are concentrated in these really high cost, horrible sort of complications, medical complications from opioid addiction. But there are also a lot of people who show up in the emergency room, and I've had colleagues, ED docs, who've looked at their census in terms of the patients coming in. A quarter to half of the patients coming through the emergency room easily have alcohol or drug involvement, but it's not necessarily apparent. When I trained, I trained at NYU, at Bellevue, in New York City, and I think like most places, you typically don't have drug testing ordered, and you don't have the results available when you're evaluating the patient. But it's usually a big part of the story, and the patients often are reluctant to talk about it for obvious reasons. So the point is that the plans are often unaware of what's driving some of their costs and the costs among some of their costliest patients, because they don't have an opioid addiction diagnosis in that patient's records. And so they can't appropriately attribute the costs to the underlying condition. So in general, when patients, and this isn't just true for opioid addiction, but when patients start getting treated for behavioral health, the savings are not necessarily apparent because there can be some cost shifting. So the plans are more focused on, well, now we're paying a couple $100s a month for the medication. We're paying a couple $100s a month for the clinical visits, and they see that as outlays, and they don't necessarily see the cost savings. Some of this is also, proving the counterfactual, where the patient's under care, and presumably that's now driving a reduction in their ED and hospital use, but you don't see the lack of the charges, right? Because they're being treated. So we've partnered. I mentioned New York State. We've partnered with some other insurance plans. In general, what we've shown is that when patients enter care with us, their total cost of care that's billed to the plan, despite the costs of buprenorphine and treatment with us, the total cost billed to the plan drops by about 60 to 70%. And when they leave care with us, they sort of drop out or disappear, those costs shoot right back up to the pre-treatment levels. That's actually in lockstep with the reductions in overdose and the reductions in mortality that we see while patients are on medication. They have a very high risk of overdose or death. They're on buprenorphine, that drops by about 70%, but it's only while they're on medication, and when they stop the medication, the risk of death jumps right back up. I've published that in the American Journal of Psychiatry and Health Affairs with colleagues with federal funding over the last 10 years. It's really striking. And so the challenge is not just to help people get into treatment, but to help them stay in treatment. And that's where the plans also can dig in their heels and say, well, the patient's been in care for a year. do they still need the medication? And we say resoundingly yes, because if they stop the medication, the costs and the risks are going to go through the roof. But the plans don't necessarily think of it that way. So it's been very difficult to negotiate these contracts.
Well, the story described of the young man could be my family story. Um, not not as severe in terms of that, but waiting around for naltrexone, waiting to get the right prescription, and an unfortunate overdose. 6 weeks in the hospital that was billed at about $500,000, and all the insurers said yes, you need to be admitted to inpatient detox. Will cover it, as opposed to denying it as not medically necessary. They would have saved themselves a whole bunch of money and
Uh,
saved a life.
yeah, it's all too common, and it keeps happening.
Is there anything else we haven't covered?
Well, one thing I'll say, there are probably a few things. One is the promise of injectable buprenorphine, and we touched on an injectable extended release naltrexone. I think injectable buprenorphine, so the weekly and monthly injections that have come to market, I think that got overshadowed by COVID. And the public health agencies obviously were very overwhelmed with COVID, and that preempted their ability to often to focus on anything else in 2020, 2021, which was right after the monthly injectable buprenorphine came to market. And I think we still need to discover, but to learn where the injectables are most helpful. And there may be some patients when they enter care where the oral sublingual buprenorphine is difficult, whereas a monthly injection gives them a lot of coverage and a lot of protection, for a whole month or longer. And I think the country could be more innovative with federal and state leadership to think about how to make it really easy to access these medications. The injectable buprenorphine is, around $1,200, $1,500 a month or more. But a lot of that cost is actually driven by the reporting system to monitor adverse events. So this gets to the whole question around regulation and these well-intentioned regulations. It's another example where they may actually be driving costs and creating barriers. But the long-acting injectables may be a better fit for some people if that's what their preference is. But we don't really have systems or structures in place to facilitate access to those.
I would, I'm sure you could probably come up with a solution to this. How would you get injectables delivered via telehealth?
Well, what we've done is partnered with the pharmaceutical company that came out with the first monthly injection. They have alternative care sites. They have a whole program where we partner with pharmacies. And so the patient's able to go in the same way you might get a flu shot, go into the pharmacy, and they can get the monthly injection. And that's worked really well for us. So it sounds a bit paradoxical as the telehealth provider that we're able to give injections, but it's through the partnerships with the pharmacy. All of our patients go to the pharmacy anyway. And so it's been a very effective way to do that.
I knew you'd have an answer.
We've been successful doing this in Pennsylvania, and we're hoping to expand it to New York very soon.
That's all the time we have for the Kingfisher Project. My guest has been Dr. Arthur Robin Williams, Associate Professor of Clinical Psychiatry at Columbia University's Division on Substance Use Disorders and a research scientist at the New York State Psychiatric Institute. Dr. Williams is also the Chief Medical Officer for Ophelia Health. Thank you, Robin, for all your good work and especially for enlightening us about Ophelia Health today. Having said that and having said goodbye, the most important thing is, how should any of our listeners find you?
Ophelia.com.
That simple.
It is.
Okay.
And there's a button. You can go on mobile, on the computer, and schedule an intake within just a few days.
Okay. I'm Bill Williams. Be sure to join me next month for another edition of the Kingfisher Project, Information Against Addiction, right here on Radio Catskill.